having internet difficulties, so if you know of anyone who is going to live stream, just let them know that we are recording this and we will post it onto our YouTube site so they can watch it afterwards. But because you're here, you've got great food, and hopefully you get to ask questions. So we're grateful that you are all here tonight. My name is Annie Short. I am the Executive Director of Northeast Wisconsin Area Health Education Center. Out of my office, we also oversee the Alliance for Wisconsin Youth. So this is a program in partnership of both of those programs. We're also fortunate to have AHEC alumni members here, and hopefully we're attending our live stream. So we're grateful for all of you to be here. As you know, this is one of those issues that continues to be something that needs to be addressed in our community. So I'm grateful that you're interested in learning how we together can continue to make a difference in our communities. As I mentioned, this was going to be live stream, maybe will still be live stream, but we are recording this session tonight, and we will have it posted onto our YouTube channel. So once that is live, you will be getting an email that will include a survey, but it will also include the link to this session. So if you want to share it with your friends and your peers, that would be great as well. At the end, we will also hopefully have some time for questions and answers. So on your table, you can see some note cards. So please feel free to write your questions down, and we can ask those at the end. If there are questions that we don't get to because of our limited time, we will make sure to work with our presenters to get the answers, and again, post those on our website so you can have access to those answers as well. With that, we're going to start with video. You'll notice that some of this is a little outdated because the FBI director is no longer the FBI director, but it's a really great video. We're only going to show the first about 10 minutes. It's a 45-minute video. I would encourage you, when you have time, to watch the whole thing, but it also just really sets a good tone for what we're going to talk about tonight. So we'll start with that. Or maybe we won't.
So good evening. My name is Brenda Beringer, and I also work at the Northeast Wisconsin Area Health Education Center. And I'm honored to be here on behalf of the Alliance for Wisconsin Youth and in partnership and the grant in Partners of Success grant that cover Rock, Dane, Columbia, and Marinette counties. I also have the privilege to introduce our next speaker, our first speaker actually, and that will be Scott Stokes. Scott currently serves as the Substance Abuse Service Section Chief at the Wisconsin Department of Health Services in the Division of Care and Treatment Services in the Bureau of Prevention, Treatment, and Recovery. You've quite a title. I practiced it, and I still can't get it. Prior to the state service, he was employed at the AIDS Resource Center of Wisconsin, the ARCW, for 24 years, and also was the statewide director for prevention services. While at ARCW, he developed and implemented the syringe access programs in 10 Wisconsin communities, as well as implementing the hepatitis C testing initiative. He also served on the National Harm Reduction Working Group and was appointed to the Wisconsin State Council on Alcohol and Other Drug Abuse, where he chaired the Prevention Committee and served as council co-chair. He also was on the World Service Board of Trustees for the Cocaine Anonymous. And last but not least, Scott has been in long-term recovery from addiction since September 19th of 1984. So without further ado, Scott Stokes.
Great, thank you. So I have 73 slides in 30 minutes, so we're going to zip pretty quickly. Basically, the goals here is to give you just a snapshot of what we're dealing with in Wisconsin related to the opioid crisis and how our state is addressing the issues. A little bit of national data. The United States makes up about 99% of hydrocodone consumption out of the whole world. Out of 100%, we take 99% of that. So we are pretty dependent on hydrocodone. Oxycodone, 73% of the world's consumption. So you could see how some of these issues got entrenched into our communities. Prescription pain reliever misuse, 6.3 million people on hydrocodone in 2017, 3.7 million people oxycodone, and about 240,000 people, 45,000 people on fentanyl. So again, a very large population of individuals that are using prescription-based drugs. Some sources on how folks obtain their prescription drugs. The majority is from a friend or a relative, 37% from their own prescriptions, 6% maybe getting it on streets from drug dealers or other ways, and then it's the 5% other ways could be getting into folks' medicine cabinets or whatever it may be. People are, they want the opioids, they will do whatever they need to do to try to find them. This is just a little depiction of the potency of heroin versus fentanyl versus carfentanil. So I get really nervous when I see these because today the illicit heroin supply is largely poisoned with fentanyl, and the more that keeps happening, the more overdose deaths we're going to be seeing. So this is really troubling for me. I am grateful we have not seen much carfentanil yet, at least in Wisconsin. There's been some on the coasts, but not too much here. And I sure hope that it doesn't make its way here anytime soon, because it could be extremely deadly. This kind of shows the growth of heroin deaths over the past several years. 2002, you can see it was about 2,000 individuals, and you fast forward to 2017, and we're at 15,000 people. And this is just heroin deaths. This isn't all the other prescription opioids. So it is a huge problem that continues to grow. I don't know if we've reached the peak yet. I'm thinking we haven't, and it's probably going to grow for a little bit longer. And if fentanyl really gets into the drug supply the way it has been, it could increase pretty enormously. In 2016, about 20% of folks that were in need of treatment actually accessed treatment. and that has improved a little bit. 2017, about 30% of the individuals who need treatment access treatment. And we're doing a lot of work to trying to expand access to medication-assisted treatment throughout the state and throughout the country. A little bit on Wisconsin. So opioid overdose death rates per 100,000 population. The first graph is all opioids, and then it breaks it down by particular drugs. So our death rate, it's about midstream in comparison to the rest of the country. Opioid overdose death rate per 100,000 kind of broken out by county. Gives you a snapshot of what that's looking like. And Annie, you're going to make these slides available as well? Okay, that's right, because if I get through too quickly, I want you to be able to go back and see them. Here's a little bit about heroin and other drugs of abuse and the trajectory of abuse that's going on throughout the years. You can see that any opioids, it's a big problem, and it continues to grow. Opioid-related hospitalizations, again, by county, they are growing on an annual basis as well. And the next one talks about opioid overdose hospitalizations. So we are continuing to see an increase in the folks making it to the emergency rooms with overdoses. The good thing is that they're getting to the emergency rooms, and when they get there, we can work with them, give them the lockdown, and hopefully reverse the overdose and get them on their way. Opioid prescriptions filled. You could see the downward trajectory there. It's about 20% decrease in 2014 to 2017. A lot of this has to do with some prescriber education, as well as the beginning of the prescription drug monitoring programs. It's really started tracking a lot of the opioid prescriptions. They're not being, I guess, passed out as graciously as they were before. There's been a lot of education around that. In some senses, they may have overdone it, where folks with legitimate pain might not be given the opioids that they really need to deal with that pain. So I know that the FDA and the CDC are really starting to look at that issue and think that maybe we need to take some steps back about what we're doing with prescribing and how we're dealing with people that have legitimate pain. And here, hydrocodone dosages purchased by Wisconsin pharmacies. You could see a pretty large decrease from 2011 to 2017. Same thing, this is just by counties. Here's the hydrocodone dosages by counties, by pharmacies, in counties. And then the oxycodone dosages purchased by Wisconsin pharmacies, again, has decreased almost a third in the same time period. So we are seeing the right trajectory. We're hoping what this is doing, it's preventing the next generation of people becoming addicted to opioids. And that's where we want to get to. Same thing, pharmacies, and it's by county. Just kind of show the differentiating. There's only a few that are above average, which is a good sign. And then also too on this one, this is the one where I think we are below the national average. So we're making some good strides in the right direction as well. So there's some health risks. Hepatitis C is a major issue for people that are using drugs, mostly dealing with injection drug use. There's a study going on with Dr. Westergaard out of Madison, where they're doing a Hep C study in rural Wisconsin, and they're seeing about a 30 to 40% HCV infection rate among young injectors. And what I mean by that, it's people 26 and under. So that's going to be a major health issue moving forward. And it's kind of still off the radar. People don't pay much attention to hepatitis C because it lays dormant for so many years. You know, you get infected, it might not start creating issues for you until 25, 30, 40 years down the road. So it's kind of like this silent epidemic that is going on. Inflammation of the liver, and it's a blood-to-blood pretty much transmission that occurs. And that's why it makes sense why injection drug users would be infected at the rate that they are, because a lot of them are sharing their works and passing the virus to each other. So There's about 90,000 people in Wisconsin that have hepatitis C, and they say that only maybe about a third to a half know that they have it. So there's a lot of testing that needs to go on. The CDC recommends that all baby boomers should be tested because before they started monitoring the blood supply, there might have been a lot of folks infected in the 50s, 60s, and 70s. So there is some baby boomer testing initiatives taking place with primary care physicians. Probably starting to see a lot of hepatitis C treatment commercials on TV, the Harvoni and some of those. That's because they're realizing just how big of a problem this is. And, it's pretty costly. So I went through 2 treatments myself in 2005 and then again 2014. And you know how you get from the pharmacy, it says your insurance saved you so much money on your prescription. Well, my 1 month supply of Harvoni, my insurance saved me $38,000. So it's just crazy on how expensive it is. But it is a cure. So it's got a 99% cure rate. So there is some possibilities of eradicating hepatitis C from the world, actually. I don't know why these slides aren't coming through. I don't know exactly what they're trying to get at here. I can't read that. Okay, yeah, so this kind of correlates hepatitis C rates along with injection drug user rates. The next one is a little bit more telling. This one is opioid overdose deaths and hepatitis C rates. And you can see it's really got about the same trajectory here. So to me, that's a real good connection that there's something going on within those populations related to injection drug use. And then there's infective endocarditis, which is basically a heart issue. A lot of people would call that like cotton fever among the drug-using population. And it is a problem. I hear from folks that work in the emergency rooms that I'm connected with that they are seeing more cases of this present into the hospital settings, and I guess it's pretty expensive to treat, but it is curable. So staying safe and some harm reduction initiatives. One of the programs that we have going, it's a pilot project with the AIDS Resource Center of Wisconsin, and they are using these fentanyl test strips. And what they're doing is when people come into the syringe exchange program to exchange their syringes, they ask them if they're using heroin or opioids, and if the answer is yes, they ask them if they'd like to be participate in this project with fentanyl test strips. So they'll give the participants these strips, and then they teach them how to test the residue that is in the cooker to see if it is contaminated with fentanyl or not. And then they give them some information on what they could do if it is positive, some choices. You can not use it. You can make sure that you don't use alone in case you overdose and have Narcan on hand, or you can cut the shot in half and not use as much as you normally would, those kinds of things. But it really is an issue with the heroin supply being poisoned with fentanyl. We are just, one bad batch away from having a major catastrophe. There were 10 overdoses in the Kenosha area within the last couple weeks. 6 of those resulted in death. And it could really happen anywhere. So naloxone is something that's been around forever. It blocks the effects of an opioid overdose. It kicks the opioid out of the brain for a period of time. It reverses, it basically revives the person. They start breathing again on their own. And there are a number of naloxone initiatives taking place. And I'll get into those a little bit more when I get into the discretionary grants discussion. And it really is the overdose. It's a respiratory issue for most cases. Really not a great need for CPR unless the heart stops, but rescue breathing is really important for this population. You got to get them oxygen. There's a standing order in Wisconsin where pharmacies can dispense naloxone without the need of a prescription, and we have about 300 Wisconsin pharmacies that participate in that program, and I know they're going to be making a push in the near future to expand that even more. So medication-assisted treatment, there's comprehensive services, medication, counseling, case management, recovery supports. All these are important to help the individual along. It's not just giving them medicine and send them on their way. They really need some behavioral health initiatives in place as well, and they need a lot of support. So many paths to recovery. Again, support groups are important, and there's a lot of work that needs to happen there. The traditional 12-step support groups might not be the right place for somebody that's on a medication-assisted treatment. A lot of the 12-step groups, they have a singleness of purpose, and to participate, you have to be free of all mind and mood-altering substances. And sometimes they think that people that are on these medications, they're still under the influence of a mood-altering substance, and they're really not welcomed into those type of environments. There are some heroin anonymous type of support groups that are starting to pop up, and it's a much more welcoming environment for these individuals. So we need to see more of that so they can get the support they need. So we have 3 products that the FDA approves. There's buprenorphine products, methadone, and naltrexone. So the buprenorphine, it's a Schedule III drug. It reduces cravings and withdrawal symptoms, and it's available at opioid treatment programs and approved practitioners as well. So there's a waiver. It's the Drug Abuse Treatment Act of 2000. Prescribers have to go through this. It's like an 8-hour training to get their buprenorphine waiver, and then they're able to prescribe up to certain levels of patients. And it's kind of odd. You don't have to go to a special training to prescribe the opioids, but you have to go to a special training to provide the treatment for it. So I don't know, something's backwards there. But anyway, we are making some headway in the state and getting some folks who are prescribing buprenorphine. You can see that we have a number that have different levels, 287 at 30, 120 at 100, and a smaller amount at the 275 patient limit. In total, if everybody was prescribing to the limits that they've been approved for, we would have 52,000 treatment slots. The problem is that many people get their data waiver and then they don't open their practice to prescribe to folks who need it for whatever reason. I think stigma plays into it. Some prescribers don't want people with active drug use maybe in their waiting room looking all dope sick when the mom and the kid is there for their checkup kind of thing. So we got a lot of stuff to do with this state related to stigma and drug users, and we're working on that pretty much daily. So, methadone is a Schedule II drug, and it suppresses withdrawal symptoms and craving. Methadone clinics have been around for a very long time in our state. Naltrexone, it's an injection 1 time a month. It's basically you have to get some labs done before you can get naltrexone. Your liver's got to be in good condition because it could tax your liver. So that's why the 7 to 10 days prior to injection, you have to be off all of opioids to make sure that you can get through those labs and you don't have any opioids on board. So the OTPs, the methadone clinics, they're specialty licensed centers. They provide all 3 forms of the MATs that are available. There's actually 21 of them in Wisconsin. They just opened the first 24/7 methadone clinic in West Allis last month. So that is up and running now, and we're hoping that that's going to really help some of those folks get engaged into treatment services, that aren't around for the 9 to 5 kind of programs. So they're also working with some law enforcement agencies to actually bring people there in real time instead of just a referral. And the patients served at the methadone clinics is growing as well, 10,000 in 2017. And we really don't have good coverage north of Highway 29. I think there's one in Marathon County, and then after that, there really isn't much at all after that. So it's really difficult. And methadone is also, the first phase or 2, you have to go there daily for your dose. There's no getting a prescription for a week or 30 days. You have to show up there. So if you live 2 hours from the clinic, that's 4 hours out of every day that you're doing this. So we have a number of federal grants that's helping us address the opioid issues. The first one, the Strategic Prevention Framework Partnership for Success. We call it SPIF PFS. And then there's the prescription drug opioid overdose that we call PDO, and then the Strategic Prevention Framework for Prescription Drugs, the SPIF-RX, the State Targeted Response, STR, and the State Opioid Response. I'm going to go through these really quickly here. So PFS 15, it's working with community coalitions in 14 counties, one tribal community, I believe, as well. And this is basically targeting 12 to 25-year-olds, and it's really about preventing misuse and abuse among those populations. So they weigh heavily on the Dose of Reality campaign. They get lots of materials from that campaign. They talk about medication security. They pass out lock boxes, lock bags, deactivation units, all those kinds of things so we can get the opioids off the streets. And then they do education for prescribers and drug recognition expert training for law enforcement, as well as a similar type of training for educators. So the Alliance for Wisconsin Youth Prevention Centers are the folks who funnel these dollars to the community coalitions and then also work closely with them to make sure that they're meeting the goals of the grants. And it's been going on for a little while now. We still have, I think it sunsets next year in the fall 2020. So the Wisconsin PDO, it's $5 million. It's $1 million a year for 5 years. The three high-need communities for that was Kenosha, Sauk, and Waukesha. And basically what this is, it's a naloxone training and distribution program. So in these counties, they train drug users, law enforcement, EMS, family members, and loved ones on how to respond to somebody's overdose. And then they also provide them with dosages of naloxone when they go through the training. So they train staff on best practices. They've got 5,300 individuals trained, and they have 90 opioid overdoses that have been reversed, that's been reported, and they do think that that's an underreporting. So the SPIF-RX, $1.8 million over 5 years. And again, these are just in Dodge and Sauk County, and most of the work that's going on there is really to help them build some community coalitions, because these were a couple areas of the state where they didn't have really good representation for coalition work. And again, it's safe prescribing practices and trying to track ways to find out where the misuse is occurring. And this sunsets in 2021. So the STR, this is, it was $7.6 million a year. And this one just ended on April 30th of this year. And there were a number of initiatives that went along with this funding. So it was, on the prevention side, awards were made to the Alliance for Wisconsin Youth. There was like $730,000 that was divvied up amongst those coalitions, the Alliance for Wisconsin Youth to divvy up to the coalitions. They had like a menu option of things that they can do in their communities, naloxone trainings, buy prescription drug drop boxes and have them placed in communities, those kinds of efforts. It also established the ED2 recovery program, and that's where they placed recovery coaches in emergency departments. And the plan there was to hook people up who have presented to an emergency room with an overdose with a recovery coach. And the idea there is to move them on a pathway to recovery after they've been released from the emergency room. And there's about 12 hospitals that are involved in that project. Marshfield Clinic got a small amount of money to equip their AmeriCorps workers on recovery coach training. There are 15 of them, so they are working in rural Wisconsin around recovery issues and helping folks in rural Wisconsin get the services they need. And also, UW-Madison is working on a toolkit for hospitals to prevent repeat overdoses. That's still in the works. It has not been completed. We funded 21 counties and 4 tribes to fund unmet treatment needs, and the criteria for them to get these dollars was they had to provide at least 2 forms of MAT, naltrexone and buprenorphine. We understood that that was a barrier for some folks, so the first year It was okay if they just provided one form, but the goal was to get to 2 forms before the end of the grant period. And we had over 900 folks that were served that first year with those dollars and those programs. And then we stood up some opioid treatment centers: Forest County, Potawatomi, Milwaukee County, Southwest Cap, Tulare, and then also we added on ARC in Madison, and these they were $250,000 grants just to begin MAT services in those communities. We had a couple of forums last year in 2018, the opioids and trauma. 200 people attended. We just did it again this last April. We had about 500 people in attendance. Then the opioid forum last year, 500 people, and this year in Green Bay area it was about 700 people. So there's a lot of interest across the state for folks to get this information. There's an ECHO program, and what this is, so let's say we get those providers out there to prescribe buprenorphine, but they're not addiction experts. They can tap into this online, basically it's a web-based program where they could work with addictionologists from UW-Madison to talk about their cases. If they have somebody that they just don't know what to do with, how to treat them, they will have those experts there. It's on Fridays, and they can present their cases and then get some expert opinion from these individuals, and that's going to be ongoing as well. Then we launched the Recovery Helpline 24/7. That went live in October of this last year, and basically it helps people find treatment services, and it also helps folks navigate insurance issues. And getting a lot of calls. We're up over 3,000 since it began in October, and we're pretty excited. Our phones in the office have stopped ringing because people are calling 211, which is really nice. So kind of liking that. And then SOR. So we're getting $11.9 million a year for this one, and this replaces STR, okay? So, and what we're doing with SOR is we're continuing all of the things that we started with STR, and then we're adding a few things because we did have more money. And then kind of icing on the cake, we were about 4 months into SOR, and we got a notice from SAMHSA that they were giving us supplemental funding as well, where they added another $6.2 million to the grant. So we got quite a bit of money on an annual basis for the next few years to continue a lot of the projects that we've already started, and then also begin some that we want to start. So again, there's going to be money going to the prevention folks for the AWI centers. We are going to be expanding naloxone training and distribution. We hope next month to launch what we're calling Narcan Direct. And that's a program where syringe access programs and local health departments can go through a training that we're putting together. They go through the training, they're considered to be one of our providers, and then when they're one of our providers, they can get all the naloxone that they need for free to then get it into the hands of folks that need it by training them. So, and this is going to be the nasal Narcan, it's not the IM formulation. So we're really excited about that because we really think that that's going to save some lives and really get naloxone into the right hands. The ED2 recovery is going to continue. The helpline is going to continue. One of the things that we want to start working on with the emergency rooms also is we want to do a pilot with where they do buprenorphine induction in the emergency room as well. So somebody comes in from an overdose, they revive them. Instead of just releasing them and they're dope sick and they're going to look for more dope, let's get them on buprenorphine and start that process there. Hook them up with a recovery coach, give them about a 3-day supply of buprenorphine, and then the recovery coach's job is to get them connected with a community provider to continue treatment. So we are going to be looking for some partners to do that in the short term. So there's regional treatment centers that have been around since 2015. This was some of the original NIGRIN legislation that really established them in rural Wisconsin where there were no services. Those are going to continue. That's the locations of them. They are going to a grant funding opportunity this year, so that it will be a competitive bid to re-up those programs in the upcoming year. And then lastly, we just had this jail-based medication-assisted treatment initiative where it was legislatively directed that we needed to get these jails on board with Vivitrol. So we had to do an RFP, and we have these county jails that now are going to be providing Vivitrol to the folks that are incarcerated before they're released. So, the idea is get them on Vivitrol before they're released, and then hopefully they're not going to go out seeking drugs when they are released and then overdose. Usually when you get released from jail, it's probably one of the most deadly times in your life if you're an opioid addicted individual, because the first thing on your mind is to go out and get high, and we're hoping that this will help prevent some of those deaths. They did add Washington County to this list. They were late to come. So. And then the UW Addiction Consultation Line. This is another support for providers where providers can call the consultation line, and it's supposed to be in real time. It goes to a pager of one of the folks at Family Medicine, and they're to respond within a half hour to whoever's paging them. It's for providers. And again, it might be providers who don't have the addiction expertise, but they could tap into somebody that does have that expertise and tap into them pretty quickly. So this is going to continue as well. Dr. Randy Brown is the medical director for this project, and he also has several other addictionologists that he contracts with who staffs that line. So we're excited about that as well, to get this as much support as we can. We're really trying to increase the number of prescribers, so we really need to try to increase the support that we can provide for them if they decide to get on that bandwagon with us. So that's it. Thanks.
Thank you, Scott, for a great presentation. So my name is Irene Chung. I am a NEWAHEC Alumni Board member, and I'm also a pharmacist in Madison, Wisconsin, completing residency at the Madison VA. I'd like to introduce our next speaker, John Lemke. John is a graduate of the University of Wisconsin-Madison School of Pharmacy. He comes to us from Stru's Pharmacy in Green Bay, where he initiated the non-vaccine injection program nearly 3 years ago. John has been an advocate for expanding pharmacy's role in treating opioid and alcohol addiction, and has had the opportunity and honor to speak on the subject matter with lawmakers, researchers, health officials, counselors, law enforcement, and many healthcare professionals. Along with him tonight is Good Kakal, the pharmacy resident at Stru's Pharmacy.
Thank you. I presume this will bring up my slideshow next year. Oh, good, it does. All right, well, oftentimes in healthcare, pharmacists are considered in the stereotypical way that you might see on television commercials with the white coat and a pill counter, and that's really not the case. We actually go through quite a bit of education and training, 4 years beyond a undergraduate degree. And there certainly are aspects of our license that are going underutilized. And I'd like to go over some of the things that we can do to hopefully chip in to help in this particular treatment. I think I'm preaching to the choir here about the mental health care issues that we have in Wisconsin. Dearth of providers across the entire state. As you may very well know, there is a lot of comorbidity between mental health and opioid abuse, and one of the problems is, of course, having access to a psychiatrist or anybody involved in mental health. As you can see by this slide, this one's a little bit old, but it hasn't really changed a whole heck of a lot as far as the number of providers needed to provide adequate coverage for mental health in general, which also would cover a lot of the opioid addicted. Wisconsin has done some legislation that does make it a little bit easier to utilize the role of pharmacists in the treatment of opioid addiction, some directly, some indirectly, but allowing pharmacists to provide injections beyond flu shots, and by allowing prescribers to delegate the authority to pharmacists to complete, well, practically anything that is deemed appropriate by that physician or within a scope of practice that is defined. We've already covered what Vivitrol is. It is a medication that does bind, unlike, well, very similar to naloxone. It binds longer, however, and it does provide coverage of those receptors for up to about a month. Generally 28 days is what we go by. Of course, your body's metabolism does vary with that. Sometimes we have folks who do supplement that treatment for a few days towards the end of that 28-day cycle, others who do just fine with a little extra. Some of the problems, though, that we have in utilizing pharmacy in the treatment of opioid addiction has to do with the fact that had been alluded to earlier by Scott, that there's a lot of different players in the overall treatment. It can't strictly be medication. It's not simply going to be a matter of law enforcement or psychiatry or any treatment out of an office, coaches. However, a lot of these players in the treatment do still operate out of silos, effectively. The independent aspects of an operation are hard to bring those walls down in such a way that it allows for a coordination of efforts and a coordination of care. Also, there has been a history in the treatment of opioid addiction as a healthcare issue or a criminal justice issue. If you go back a couple of decades, you find that a lot of the heroin addiction treatment was dealt with as a criminal issue and through the law enforcement, whereas as that has expanded, we have seen a lot more addressed as a healthcare crisis, and truthfully, it's definitely crossed over for the purposes of treatment between the two, and there just hasn't been necessarily the level of coordination that we'd like to see. However, it is certainly getting there, as Scott had brought up the different partnerships with treatment before release from prison. And of course, there's always levels of bureaucracy. I personally had worked for state organizations and private organizations. You think of bureaucracy, it's not just a governmental thing. A lot of different private organizations I worked with have the layers that you need to go through in order to affect any change or try to bring down those barriers that don't allow for coordination of care. And all of that together does lead to one of the biggest problems that I see in my practice, and that is someone may start treatment but quickly fall off the radar. And it's issues like this that do increase the rates of recidivism. One of the other big problems that we've seen is patient access to care. It's not just a matter of accessing providers, but places where they can seek treatment, especially in the rural areas, places where they can be connected with recovery coaches or counselors. Specifically for my area in pharmacy, we do see that with Vivitrol, a lot of the insurers will require what's called a prior authorization, where it could take a number of days to get the authorization for their insurance to cover. Luckily, Wisconsin State Insurance does not have that, but plenty of private insurers do. On a Friday afternoon, we have someone come in ready to seek treatment. We get a prior authorization, that's fine, all right. Now, Monday perhaps that will go through the insurance. Just don't use over the entire weekend, that should be no problem, right? Well, it clearly doesn't work that way. Another problem we run into with the insurance companies is a matter of who gets to provide the medication. Vivitrol does cost about $1,300 for a month's supply, and specific pharmacies are sometimes required by the insurers that are perhaps part of their economies of scope, but again, it's something that would require an extra day. The drug has to be shipped overnight. Those 24 hours are crucial. Time to treatment when someone is ready is absolutely crucial in maintaining the likelihood of continuing with treatment or starting it in the first place. Accessibility to providers is certainly an issue, as you can imagine, but it's one of those areas where it's not just a geographic thing, but also a matter of getting an appointment to see somebody. We had seen earlier how there's the different providers, but also as far as general practitioners or other providers or physicians in the area are uncomfortable with providing or prescribing the medication Vivitrol. A lot of that has to do with education on the subject itself or the medication itself. Patients do have another issue, even if they have a prescription for the medication, and where do you go to get the injection? I know some offices that I work with, they don't provide the actual injection on site, or you have to do it by an appointment where it works on their schedule, and you can't necessarily drop in when you're ready, or it's, again, that 9 to 5 effect where it just may not work. We have patients that are folks who have to come in during off hours, and it's relatively difficult to get a physician's appointment at 8 o'clock at night or on a Saturday. And then there is the stigma as well that can go along with any kind of treatment, whether it be with buprenorphine or with naltrexone. The patients who we've spoken to might not have access to transportation. A lot of folks we deal with do not have driver's license. They need to get rides to where they're going, and there's certainly a stigma to going to a clinic to get that daily dose of methadone, or to go someplace where it's clear you're going to seek treatment for opioid addiction. And that can be a limiting factor in continuing or even initiating treatment. And all of that, again, once you even start, is going to increase the likelihood of someone falling off of their treatment. Now, pharmacy offers a few advantages in the sense that when we know someone, whether it's coming from a provider's office or from a treatment program, jail, if they're going to be an insurance issue, that can be dealt with up front. So as soon as we're ready to treat, we have the ability to do so without having to worry about who's going to pay for the medication, how long it's going to take. Not much I can do about the specified dispenser. When insurance companies want to do that, we can lobby for it. In fact, in Wisconsin, actually, there is a relatively open audience in the state legislature for doing what it takes to bring down those barriers and walls. We're not seeing that in every state. And when it comes to accessibility to providers, there has been a lot more utilization of telehealth to reach psychiatrists, nurse practitioners who are working in the field to make those appointments that are so difficult to get in for not just mental health, but for opioid addiction or really anything that's comorbid. Establishing partnerships is something where there, I believe, is a lot of potential for pharmacy. Whether or not they are providing injections, as it's a very easy access point for getting a chance to not just receive the drug, but also sit down and perhaps Skype with the provider for your treatment, not having to necessarily have the restrictions on the times or appointments that everyone going to a physical office would face. The big thing I believe that we offer is in terms of locations that folks can get their injection. Earlier slides that Scott had shown has highlighted just how spread out the problem is and how few places necessarily are available for seeking treatment or receiving any medication like Vivitrol. And when pharmacies are involved, we tend to be in places that are high volume. Take, for example, shopping centers, commercial districts, all things that are on a bus line, whereas you don't necessarily see that with provider offices. Having that accessibility and something where transportation is an easier issue is one thing, and also just in the community in general. Further, our pharmacy has hours that are convenient to folks who would shop, which is not the same as convenient to appointments during the week for a provider's office. So folks, again, who need that evening or weekend hours are available for that, and something where it's a lot easier to get an appointment with us. It doesn't cost $90 to walk in the door, and you don't need 2-month advance notice. And if you're catching a ride with whoever to go to the treatment center, that's one thing, but to get a ride to a pharmacy, everybody goes to a pharmacy. The stigma of where we're going or what we're doing, it's not as big of a concern. This is one of the things that when we initiated our program, hadn't really thought of much until the folks we were seeing started bringing it up to our attention. And I hadn't really given much credence to that thought, but it is certainly an issue that we face. If we can improve all these areas, we will and have seen less recidivism in opioid treatment. There are some other problems, however, that we do face that I believe we got some decent solutions to, particularly for us as pharmacists and for pharmacies in general. One is, when it comes to getting Vivitrol, there is, well, like a lot of drugs, a lack of reimbursement, which provides disincentives for us to participate. I can tell you that on a $1,300 box of Vivitrol every month, earn anywhere from $12 to $67. And that's an awful lot of money to have tied up from month to month to earn $12 to $67, which makes it difficult to sell to those who control the spreadsheets and the purse strings for a pharmacy to get involved. There's also a lack of reimbursement for any of the services that are provided and supply it takes to do so as well. We cannot bill for the service of giving an injection. We get reimbursed for flu shots at a reasonable rate for the time it takes for pharmacists to administer. We have no such avenue for providing Vivitrol injections. So there's zero reimbursement for the professional service. And it's our dollars that go towards the actual supplies it takes, the testing cups for drug screening, the just standard injection items like Band-Aids, alcohol swabs. This is an example of the drug screen that we use, a urine drug screen that takes 5 minutes or less to read. Does test for 8 different medications, including methadone, opioids, and we purchase these for around $5 a cup, for which we cannot bill. And when we're getting $12 reimbursement, that's almost half of what we're talking about. And these have to be sent off for quality assurance as well. We've put together a spreadsheet. It's very difficult to read, and reasonably so. That's kind of by intention. Oh, it's cutting off the bottom. Based on the lowest reimbursement rate we receive, it costs the pharmacy about $100 in terms of money and time spent by pharmacists to inject. $100 loss every injection we give, so there's clearly a disincentive under current circumstances and reimbursement models. Another issue that pharmacies do face, although they might be more likely accessible points for patients, is that a lot of pharmacies are one-person shows. There's a lot of time involved in administering a Vivitrol injection, especially for the first injection. It's not like a flu shot where you can duck behind a curtain, get poked in the arm, and you're out of there in less than a minute. Our first appointment with a Vivitrol patient will last a minimum of 30 minutes, and each follow-up visit, you can count on double-digit minutes. You're not just popping in and popping out. A lot of consultation, a lot of counseling, ensuring coordination of care, monitoring, all takes the time, and that's something that's simply impractical for many pharmacies and pharmacists. The silo effect had been brought up earlier, and one of the coordination problems that we both have an opportunity to address and remain a problem for us is what we do from when we have the person in our offices, in our treatment center. And the monitoring aspect of this is not just a matter of making sure that those different players and stakeholders are involved in the treatment plan, but in reaction to the medication itself. First time one does get to their Vivitrol injection, although we test for the presence of opioids in the urine, we may induce a withdrawal that is going to require clinical monitoring. And that means I have somebody at least 15 minutes inside the pharmacy that we have to keep our eye on while we're also doing the rest of our work. And unlike a flu shot where you can duck behind a curtain at the CVS or what have you, Vivitrol injection is a little more sensitive topic. It's a gluteal injection. You're discussing a sensitive situation. So you really need a actual clinic room to do this treatment in. Without open air space, certainly not something that's got shoppers walking around while this is happening. Most pharmacies don't have rooms like this. Goody and I are lucky to work at a location where we have an adequate space to provide these injections and consult patients in a way that doesn't inhibit pre-communication. And another problem, of course, is the folks who we might get in one time and we never see them again and we can't access their patients, and it's difficult with the silo effect to maintain that communication. In our treatment, as far as how many folks that we see a second time or how many folks stick with the program, we do see sort of a bimodal graph spread out where there's a little bit of a spike at the folks who come in once or have one appointment but don't show up, and then baseline out to where we have folks who tend to stick with the program and will receive up to 12 months worth of injection. So you either seem to get on the program and stick with it or not. We have very few people that show up for 3 or 4 injections and that's it. We stop seeing them again unless incarceration or something is involved or some other aspect of their life. So amongst these disincentives, of course, increases the rates of recidivism. I didn't mention the professional risks, but there are risks involved as far as potential litigation for any kind of injury occurred from alleged or true injection issues or whatever you have. And in my experience, there are different rates of likelihood of litigation. And unfortunately, when it comes to folks who have been incarcerated, there's more incentive to litigate. So one of the things that we can do to hopefully increase more pharmacies participating in programs like this is I need more than $12 to carry a $1,300 drug in the pharmacy and still justify that to the executives. We do still need to meet payroll. Also, being able to bill for professional services is one thing where there is support for in general. Just making that happen is the next thing. Again, luckily in Wisconsin, we have a legislative body that is receptive to the idea. The only issue now is how do we put that in place. But that is the kind of thing that nationwide would really expand participation as the incentives financially increase for pharmacies. Of course, removing different barriers of communication with different stakeholders would certainly help. I can tell you an example from our practice. We have a patient that walks in that's ready for treatment. They'd like to start right away. Maybe they have an issue with their drug screen. This happened not terribly long ago where we had somebody who was at a dentist a couple days before and had been given a Vicodin. Drugs team did come back positive. Patient was ready to treat. Patient was willing to take the risk of any kind of precipitation of withdrawal. And I couldn't get, by order of the collaborative practice agreement we had with this particular physician, couldn't get him on the phone. I don't know if anyone's ever tried to call and reach a physician, but from a pharmacy's perspective, you tend to call a receptionist who tends to take a message and tends to pass that on to a nurse, and the nurse takes the message and brings it to the provider. The provider will provide a communication back to the nurse will provide communication either directly to the pharmacist or back to the receptionist who gives us a call. If you've ever played the game telephone in your life, you know how those extra words get inserted and removed from the communication. That sometimes confuses the message and also delays that time of treatment. In this particular instance, our fellow had to go to work, and by the time we did hear back, we didn't have him in our presence anymore, and sure enough, it was a Friday, and come Monday, when we had everything in place and ready to go, didn't show up. Another thing that does help us, technology provision. We mentioned the ability to do telehealth. Well, pharmacy is a great place to do this. It's not very difficult. In the same rooms we'd be injecting into have Skype capability. We have partnerships set up with a group out of, LA Health is the group. They serve a lot of different rural areas, and we can have our patients immediately, while they're at their appointment here, all coordinated with their appointment with the nurse practitioner or psychiatrist, and also with any other component of the overall treatment. All of this in place does, again, increase incentives for participation in pharmacy and add just one more link into that chain of treatment that is necessary. But in summary, from our perspective as treating for a while, we certainly are underused. The folks we have, and certainly our practice, I imagine that most pharmacies are trained and capable of providing this service. We can be granted the authority to participate, whether it's just from administering the injections to anything higher than that. And there are plenty of different advantages in terms of accessibility, in terms of the reduction of stigma, and in terms of follow-up care and the cost of actually seeing somebody. You can walk into your pharmacy. It costs you $0 to talk to a pharmacist, and you don't need an appointment to do so. All this inclusion does lead to better outcomes and better treatments for patients. And I think that's all I got, but we are saving questions to the end, I believe, so let's hold off on that last slide.
All right, thank you, John. I'd like to introduce our next speaker, Dr. Brian Konowalchuk. Dr. Konowalchuk is the Medical Director of Employer Services and member of the Advocate Aurora Opiate Steering Committee. Prior to joining Aurora in 2018, he served as the chair of the Opiate Steering Committee at Essentia Health for 8 years. He also served as Division Chair of Neurosciences, Chief of Medical Specialties, and was Medical Director of the Spinal Rehabilitation Program at Essentia Health. Thank you.
Let's see if I get a mobile microphone here. Cord. Okay. Fantastic. Is it working? Are we good? Yeah, the other one's the functioning one. I have to resort to the podium, but like ambulatory. All right, well, it's really, can you hear me okay? Is that good? It's a distinct pleasure to be here. I have given more countless presentations on opiates than I can even remember. I started about 8 years ago at Essentia Health. It was before the opiate thing was really such a big issue. We had seen statistics going crazy. We had seen our primary care clinics become inundated with opiate prescribing. We're going to go through a little bit of that. And we started to see the warning signs, and the warning signs were building for what this opiate problem really is. And then we started to address the problem at Essentia Health. Who here is familiar with Essentia Health? A little bit. So Essentia Health is really northwestern Wisconsin, across northern Minnesota, down into Fargo, North Dakota. Very much a rural healthcare center. We covered about 500,000 patient lives, and it will become relevant in several ways as we go through this talk. But when we started this, it was really hard to convince people that opiates were a problem. I'm going to go through a little bit of the history of prescribing. And as we went through the journey, it was quite fun. We put some pretty elaborate processes into place, and by the end, it felt like we were playing catch up because all of a sudden it caught on, and nationally there were so many things going on. We see all the good programs that are being developed. Just a couple of comments on what I heard previously. To the previous thing, pharmacy plays a gigantic role. And in Minnesota, Health Partners, one of the big organizations in the Twin Cities area, and ourselves up in the north, used pharmacy in brand new ways. And pharmacists became part of our real partners in addressing this problem, both at the committee level in assigning things, but also direct partners when it came to weeding and dealing with patients. It's a tremendous thing. I think it's actually been, in some ways, a benefit for the pharmacy communities where they can catch up and actually increase their access to direct patient treatment, which I think has been one of the unfortunate limitations in pharmacy practice. But this opioid problem as an epidemic requires all of us to work together, and it has opened up some big doors, and pharmacy has been an invaluable partner. Our community partners, on the other hand, the same thing, police, law enforcement, those things, have played an unbelievable role. And I'm now on the steering committee for our Advocate Aurora, which is actually a really gigantic service area. And I would love to talk to you more about what partnerships we do, particularly with our ERs and other things, and some of the issues we have. When we talk about the, I'm gonna go off a little bit based on what I heard, and I presented a lot based on what I was asked to present on alternative medication treatments for opiates, and we'll go through that a little bit, but I think the opiate issue here is really the larger thing to talk about. But we talked about in that first discussion, also some of the second, how are we not providing these injections, or how are we not providing more naloxone and other treatments in our primary care clinics? And I will tell you that we address this amongst our 3-state area of primary care clinics. And if you take a step back, and we'll go through this, primary care became the prescriber of opiate medications. Surgery has done a lot of it, but about 65% of all the opiates being prescribed are coming from primary care offices. Well, why is that such a huge problem? Number one drug prescribed in this country, hydrocodone. For many, many years, that's been true and standing. But when this problem was developed, it was promised to these doctors that, don't worry, if your patient has pain, they're not going to become addicted or dependent. This is a great thing, you have to do it. And then actually, there was fear of retribution in the medical boards that if we don't give them opiate medications, we're doing malpractice. Large patient panels were developed. How many of those doctors had doctor's offices set up for addiction, or even had any training in addiction, or even today have any training in addiction? Almost zero. So then we go to our primary care offices and say, okay, at Essentia Health, we have 15,000 patients now that are on high-dose opiates that have been dependent for years. What do we do with them? You know what our primary care says? We don't know what to do. We're not addiction specialists. Send them to the pain doctors. Guess how many pain doctors exist in this country? Or addiction specialists? Very, very limited. So we have a huge community problem. We became stuck with a moral crisis and dilemma. We have thousands of patients across our continuum that are addicted to opiates. What do we do with them? We know it's dangerous for them. It's dangerous to their life and health long term. Do we continue to prescribe this? Well, wait. What happens if we don't continue to prescribe this? Then they go to the streets and they look to other drugs and alternatives. We have created a very, very difficult problem to solve. And now there are tremendous resources nationally in research, and we can create great partnerships. But make no mistake, we have created a huge social problem. And it is probably, as the 20th century, the biggest medical mistake that we have made. All right. Going from there, let's take a little step back. Take just a moment. This is Prince. And at the time I was presenting to our Essentia board a couple years ago, and at Essentia we elevated this entire opioid crisis to one of our major system initiatives. Prince had died. I think it's worthwhile to look at Prince, and I love the music and watch the passion, and he does a bow out to the end. And to me, it was really symbolic of the bow out that he made to society as a representative of this opiate problem. So it's been an hour of talk. We can take a minute to appreciate that. Can we get a little more volume? Maybe not. All right, that's got to be a lot better than listening to me talking. In the meantime, I got a little freedom with this mic. It's a horrible loss of life and talent and a loss to our society. And that's just an example, obviously, a talented one. One brings out emotion. But, for our young people now, the number one killer of our young people, ahead of motor vehicle accidents and everything else, we are wasting a generation and the addiction and other problems that go with it. This beautiful young lady here, Casey Elkington was a young lady in western Minnesota who found her way into drugs the same tragic way we've seen happen so many times. And this became an inspiration for the community to band together and resulted in the visit and a community gathering with Senator Amy Klobuchar and actually resulted in national legislation. And her mother said this, and I think, the stories of understanding how we got here and the human stories are so important, but her mother said this: ultimately she's the victim of overprescribing. And that is what brought her to a world that she had no business being in, with criminals who had violent backgrounds. I think we heard about that in the first lecture. And it was an individual with abdominal pain who went down this path of opiate treatment, which created this dependency, this addiction, and eventually led her into that world. And to bring it more locally, this is a mother who lost both of her young sons at 23 and 24 in Marinette, Minnesota. And, a graph just showing how we've had this skyrocketing rates of these deaths occurring across our country. So it's not just the famous people, or it's not just somebody else's problem. And actually, I bet if I asked people to raise their hand who's had a loved one in this room or a friend that is suffering or has suffered or has died from this problem, it would probably be pretty close to universal. And in fact, just in sort of an interesting thing, we had an opiate committee at Sentia that was working to do this stuff. And during the committee's work early on, with an emergency doctor representative whose son died of an opiate overdose that was on our committee. And it's amazing stories. It has really rocked our life and world. What are we going to do? Well, I'm going to go through a little bit of the birth of how we got here and really address this from the medical perspective. I think that's really helpful. I know we have some doctors in the audience, pharmacists, and also some other representatives in the health and community sectors. And I think that really appeals to everybody. And what we're going to do that, I think, will help us understand where we were and give us a little thought into how we create solutions. So first of all, let's go back a little bit and just say, what are opiates? Well, opiates actually come from this beautiful little plant here, which gives off the poppy seed. And they've been around for thousands of years. And really in early Iraqi area and Mesopotamia, they were used and called the joy plant. It was known for its euphoric qualities back in the day. They spread very much through the ancient empires, all the way across India, China, and Europe. And then migrated really into modern medicines by the early 1500s and all the way up to the early 1900s. They were pretty ubiquitous in a lot of our medications. There was always a tincture of heroin or something in our medications. In the United States, because of significant concern for risk of addiction, the anti-heroin law was passed, and that was the first time that there was really significant change in the way opiates were being used, and it really stamped down on the amount of heroin that was going out in our country. It's interesting if you talk to doctors who are of the older persuasion. Is that politically correct? I'm not going to say it anymore, but we educated all of our doctors, and I had a tremendous amount of conversation with all of them, but the older doctors, the ones that are retired, were showing up at the alumni events or maybe still practicing at the end. Remember the day when we didn't give opiates as a medication in this country because we were concerned about their danger, and they lived through that area where they convinced that they should give them. And it was interesting to hear sort of a mixed bag. Some of them said now that they'd gotten back into things had swung a little bit the other way. Some said, thank goodness, we knew this was a huge problem. We should have never gotten into it. We knew this 50 years ago that this was a problem. And others said, this is really hard because now I've been giving all my patients these medications for 20 years and somebody's telling me that I'm wrong. And that's really hard to swallow. Did I treat all these patients wrong for all those years? Those are the kind of challenges and personal challenges people have to deal with. We put a committee together, and for a long time there was a yin and yang. People would say, these drugs are really dangerous, but others would say, yeah, but they're really helping my patient. We had a pain doctor that was like that. Ben and us were making progress in Essentia as an organization. We ended up having a meeting where we get together, and I call it the Come to Jesus meeting. It was like an AA meeting. We brought in law enforcement, lots of scientific articles and other things, and we finally sat down together and had this deep discussion. And this doctor who had really fought the process for a long time said, I think that I was wrong. And he said, I feel like I'm a recovering alcoholic right now, and I need to deal with what I've done. It's been a really emotional issue, and it's really been propagated on beliefs and not on good science. The president of our organization found this quote, and I gave this quote to all of our family practice clinicians, and I think it really, it's a thought-inspiring quote, and it's not nice, but it really, if you change some of these words to pharmacists and physicians or a medical community, how does this quote come out? So the picture you see here is William Burroughs. He was born in St. Louis, Missouri, to a rich family, the Burroughs Corporation. A very smart kid. He went to Harvard and studied English and anthropology, and of all places went to Vienna, Austria to go to medical school. Well, along the way, he found himself into a heroin problem and traveled much of the back alleys of Europe chasing his heroin problem, and eventually came back to the United States, recovered, and became a really famous writer. He said this here. He says, the junk merchant, and talking about junk, not the stuff you throw out in the garbage at the end of a big meal, but junk, the heroin, does not sell his product to the consumer. He sells the consumer to his product. He does not improve and simplify his merchandise. He degrades and simplifies the client. So, the way I like to think about it is, what do we do in medical practices when we deal with chronic pain? How have we dealt with chronic pain for 30 years? In some places, okay. In other places, a simple pill, 15 minutes and a simple pill. We started, and I'm going to show you another slide, really in about the 1980s. Before 1985, there was very little opiate being prescribed in this country. We started to prescribe it effectively for cancer pain. Okay, it was actually pretty effective. And the idea became, wait a minute, we have a lot of pain in this country. If it's effective for cancer pain, think if we could eradicate pain in this country. If we're a pharmaceutical company, we're selling right now to 2% of the population. What would happen if we could sell to 100% of the population? They married themselves to some of our doctors, particularly in the pain community, and they perpetuated a story that if your patient has pain, don't worry about it. They don't have to worry about those issues of addiction or dependence, or at least they're not very significant or they're trivial. And thus started this process of eradicating pain in our country. We created things like pain is the fifth vital sign, and this whole era began. This started really this production campaign, which has resulted in lawsuits. This one was an older lawsuit, which had to deal with OxyContin. Of course, we're relitigating this entire thing right now. This came from John Brownlee at the United States Department of Justice. He said this: simply put, the genesis of OxyContin was not the result of good science or lab experiment. It was the child of marketeers and bottom line financial decision making. While we intended to do a great service for pain, this is truly what drove a lot of the discussion. This resulted in this. By 2007, Grunkenmeyer published this in an article. He said, this is what's happening in medical clinics in America. Patient comes into the clinic now with demonstrated pain. Their tests are negative, their exam is atypical. We don't even have a formal diagnosis, but we send them out the door with prescription medication. And those of us who practice medicine through this time kind of understand this, I think. It happened all the time. Jane Ballantyne, she was a anesthesiologist from Oxford, came to the United States, and lived through this era and was one of these pain doctors that was involved through the growth of these medications. I had a lovely cup of coffee with her in Duluth, Minnesota. And she said this, and she was actually, by the way, one of the pioneers that was really instrumental in enacting laws in the state of Washington, which actually began to have legal limitations on prescribing practices. But she said this: the treatment of pain with any number of approaches other than opioids can be held up as compassionate care. In other words, there's lots of things out there, but most of them require more time than writing a prescription, and time is medicine's least valued commodity. Of course, we can blame the insurance companies for that. I'm just kidding. We heard a little bit of being on the insurance companies. Really, my wife happens to work for an insurance company, so it's all the insurance company's fault. And this happened in medical practices. For clinicians, I think this is interesting to learn from it. It creates a great discussion. This is some of the problems we have to deal with. So when I dealt with our doctors in prescribing and changing the prescribing habits, if I sat in with a room the size of doctors and said, we prescribe too many opiates, this is a problem, 100% of them will say, you're absolutely right. We've got to fix this problem. We shouldn't do this anymore. And then when we reviewed their practices a month later, guess what we saw? 100% of them, not one, changed their practice. Okay? And there are multiple reasons for that. Well, number one, habits are hard to change, but it's also what happens in the office. Well, there are a lot of things that you go through. And Miles Belgrade, he's a pain doctor from the University of Minnesota, very fascinating individual, and he allowed us to use this slide for a lot of our education. But he gave this talk, and he said, well, there's several things going on. He calls them the 7 deadly sins of prescribing. The first is we lump our pain. We tremendously lumped our pain. And if we have time, we'll go through a little bit of that. But we began to treat acute pain and chronic pain and all kinds of different pain with opiate medications. So if somebody comes into you and says, you know, I'm out of 10 pain, and my head hurts and my back hurts, okay, I'm going to give you an opiate. Sometimes that was the end of the treatment. What was really going on with that chronic pain complaint? Was it really opiate-induced pain? Well, we gave them a dependent medication, addictive medication. Did we actually address their psychology or their depression or other things? So we lumped them, we treated with opiate. We also got into opiate worship, and we see this a lot. And I think, earlier, they mentioned that we have to go back to opiates because we're underprescribed. We have to be careful of this. We believe that if we don't give that opiate, we're undertreating somebody's pain. With chronic pain, we have to ask the question if it's ever useful, and I'll get into that a little bit more. For acute pain, there's a role. For surgical pain, there's a role. For chronic pain, we have to be very, very careful. We have people on tremendously high doses of pain opiate levels that we're wiping them out and saying we need to give them more opiates because we're not treating their pain to the point that we put them to their death. That's a form of opiate worship. And then you say we need to reduce what we can't, they're in pain. And we believe that they can't live a life effectively without opiates. Stupidity, giving high doses, filling prescriptions when the opiate agreements are routinely broken, things like that. We've done a lot of that. Servitude. This is a real challenge. I'm working with a doctor in Hibbing, Minnesota, a small community. He takes care of all the family members. The patient's in his office says, I need more opiates. My back really hurts. What happens with that doctor? Says, I don't know if that's a good idea, but he really doesn't want that patient walking out the door and telling his cousin and his mom and everybody else that treats that that's a bad doctor. It's a tough position to be in. You see them at the grocery store and everywhere else. Perfectionism. I know this applies to our pharmacists more than our doctors. Okay, we're all type A personalities. Everybody wants 100% on their test. You give them a 10 out of 10 pain score. We want their pain to be 10 out of 10. They come in your office. You give them a pain scale. What's your pain? Well, it's 10 out of 10. You give them another test. It's 8 out of 10. It's 6 out of 10. Okay, you keep upping your medication. It's unrealistic to get to 0, but nobody taught people you're not ever going to get to 0. Don't try to get there, and you keep a ramp up going. Asking for trouble at prescribing opiates and benzos, big time problem. We had a patient die in an organization, a telephone refill, even though we should have known better for somebody on both COPD, other things, respiratory suppressants. And ignoring the elephant. We don't deal with that patient's depression, anxiety, addiction issues that are apparent to us, but we keep prescribing. What happened? Well, over those years, we saw massive growth of these medications. Over a very short time, oxycodone prescribing doubled fentanyl by 500%, methadone by 1,000%. To where for years, I already alluded to this, for years it was the #1 prescribed drug. And this is what it looked like. And these are statistics. And this is what I say before 1985, very little prescribing was done. And when I have physicians there, they say, well, we need to continue prescribing pain because we can't stop in this country because we're not going to be helping people's pain. Before 1985, we didn't do it, and how much more pain do we have in 1985 than we have today? Some might argue actually less. A couple of things have contributed to that, and here's a list of adverse effects that go on with opiates. This is one that doctors have routinely avoided, thinking my patient, is on these stable and can drive. These aren't pain medications, and we have to be careful about these things. But the two I think are even more significant. Dependence is inevitable. There's a whole discussion about when addiction starts and that whole addiction piece. But if you're on these things around the clock for any period of time, you will become dependent, and your body will make changes. The other one that's a real problem that was not recognized is hyperalgesia. Over time, and this is the problem with chronic prescribing of opiates, over time, your body adjusts and you begin to feel more pain for everything. And if opiates are your treatment for pain, what happens when you begin to feel more pain? You up the opiates, and on you go. Jane Ballantyne, we printed this out laminated. This became part of our patient education packet at Essentia Health. Jane Ballantyne wrote this, and it looks like this. So somebody starts here and they're in a normal state, and you give them an opiate medication for pain. Okay, this is a good thing. Opiates are a very effective medication. There's no question about it. When you first give it to them, they're up here. They have tremendous pain control, and they have tremendous euphoria. It had the anticipated effect. What happens over time? You continue that dose. Pretty soon you're giving them that pill and they're kind of back to normal. But doc, my pain is there. I want you to help me. So you up their dose. Never get back actually quite to the state they were at with their euphoria and analgesia, but they get better and you give them an upper dose again. And then pretty soon over time you're living right here. You're living in a state of dysphoria and a hyperalgesia. And this becomes a difficult conversation because you sit down with your patient and say, I really think these opiates aren't helping you. But they are. They're helping my pain. how do you convey to somebody that they're actually living down here? So this graph is very helpful to do that. Once we get you off of your medications and give you enough time to rehabilitate, you're going to go from here on your medications to here without, minus some other side effects, and certainly not having to go to doctor's offices all the time. But they have to understand that you have thousands of patients that are out now on dependent opiate medications. You have to have a mechanism to begin the discussion, and it's very important to understand. And this is most important to that, to this whole discussion right here, and it goes back to what I said about what are we doing in the future. Despite extensive use for chronic pain, little reduction in pain scores, minimal improvement in functional outcomes, and exacerbation of depression and anxiety. On the flip side, more than 70,000 deaths just in 2018 alone. There's no balance to that equation anymore. It just doesn't exist. One of my favorite studies was done in Denmark, 10,000 patient questionnaire. They controlled for all the different patient factors that they could have found those using opiates had less employment, more healthcare use, higher pain scores. It doesn't have the intended effect long term. So what do? Well, when we sit down with a patient, we have to sit down and say, what are our true options in life? Okay, what can we do? Because before it was, well, we're going to get rid of your pain. We gave you the pain scale. What can we do? Now we need to sit down and say, well, you need to understand that pain is a part of the human condition and it's incurable. And you're going to have to live with some. On the flip side, there are other things we can do to help. Simple things. Heat, ice, over-the-counter medication. Make a difference a little bit. We don't have a cure. We have to do little things. One that is so often neglected is probably the most helpful, stretching exercise. How many of us have prescribed high dose of opiates for a patient who doesn't stretch or exercise? Endorphin release, tissue healing, endurance, better coping ability, all of those things. And we have to recognize better alternative therapies. One of the problems that we have had is certainly, and it's kind of ironic, our high dose opiate gets paid for, but if we look at some of these alternative therapies, which are at least arguably safer, there's no coverage for it. So we're back into that dilemma, that 15-minute visit and a prescription. And there are prescription medications. How are we doing for time? All right, we'll get those into those a little bit, but you can read on the rest. When we're prescribing medications for chronic pain or for pain in general, then we have to understand that there are different situations, and those situations require different prescribing. There's acute issues, post-operative issues, malignant issues, and chronic issues. And I would argue when it comes to chronic pain, it's very often much less about actually the pain than it is about all these other issues. Here in the treatment, truthfully, is not generally, it's often an opiate medication, but it's treating their conditioning, mood, their depression, their experiences, their meaning in life, all of those hard things to give them value back and give them coping skills. There are non-opioid medications for pain that can help, and what you use is dependent on the activation site. But again, for chronic pain, this is a piece of it. Medications aren't going to be your total solution, just a small piece of it. All right, so the common ones, acetaminophen, okay? Obviously a well-known over-the-counter medication. Your anti-inflammatories, there's many, many varieties. Antidepressants of a variety, your anticonvulsants, simple lytics, muscle relaxers, and local anesthetics, all can play a role. None can cure your pain. Does that make sense? I want to make some comments on acute and chronic pain. For acute pain, opiates can have effectiveness, but they should be given on a limited basis. Recent CDC guidelines say 3 to 7 days. We work tremendously hard with our surgical groups. You should be probably prescribing less than 7 days for minor procedures, maybe 2 weeks for major procedures. After that, you need to be concerned, maybe get some help involved to make sure that you're not going down the wrong pathway. For our surgeons in rural practices, this is kind of wait. These patients, if they need to be seen again, they're an hour and a half away. So I need to give them those 80 OxyContins or whatever. It's a good patient thing. It's a problem. So systems have to figure out how to address that stuff. For chronic pain, some people say it's just not effective for chronic pain because of the issues I showed you. I think that's very debatable. We can all talk about that. But around-the-clock narcotics definitely present a problem. Then we have normal nociceptive pain. You injure your finger, a signal travels up your nerves through your spinal cord to your brain. It's very effectively treated superficially, or your neuropathic pain, where you have now injured nerves. Very different mechanisms, take very different medications to treat. I put together this slide so you could just understand some of your options when you're getting into treating those kind of things. We won't go through it in great detail. We're getting a little tight. So I'll just let you read that. There are some good details here about some prescribing doses and major side effects. It's a good reference for you. One comment I have to make, because be careful with your muscle relaxers. When you give a patient a muscle relaxer because they come in with their back sprain or whatever it might be, most of the time you're giving flexor, it's not really a muscle relaxer, it's a sedative. Let your patient know that's probably not going to do really a whole lot for your muscle, but you're going to sleep a lot better. But don't take it during the day because you're going to sleep a lot better. You look something like that. When it comes to actual documented benefits of these muscle relaxers, cyclobenzaprine has had some shown effect in the literature with fibromyalgia, low back pain, and TMJ, tizanidine with central pain syndromes, and baclofen with trigeminal neuralgia and CNS spasticity. So that's really where the evidence body lies. Some more stuff on your anticonvulsants. The one thing I might want to pull out on these particular gabapentin and pregabalin, these actually might be helpful preoperatively. A lot has changed in the operative world with how we treat pain, even getting away from as many narcotics. And there's been tremendous success in treating people with alternative therapies, mindfulness-based therapies, hypnosis, other things. They actually report higher pain relief than the patients traditionally treating with opiates. We don't have great systems across the country, but in the universities that have done this, it's really been an up-and-coming thing. But preemptive analgesia and dosing of these medications, and I have them here, can actually be helpful for that. Topical medications can play a role. One of my favorite is Voltaren gel. I give it to lots of patients. It's an anti-inflammatory, but it does 2 things. Number one, it gives possibly some analgesic effect. But the other thing it does is it gives patients something to rub into their affected area, which makes them feel like they're doing something. I think it's got a double effect. They're actively taking part in their role rather than taking a pill. There is generic. Sometimes they get denied at the pharmacy, like pre-authorization for that kind of thing. And there are multiple other modalities that can be used. Physical therapy, integrated medicine, a brand new field that looks at a variety of holistic ways of treating people. And I will say, traditionally, we haven't looked at these things. We've said, look, that doesn't provide a cure. We're not going to give people treatments that aren't a cure. That's not well studied in the literature. Well, when it comes to treating chronic pain, what we have to understand is sometimes people need a helping hand. They need something safe, whether you can prove it or not, that makes that person feel better, whether it's stress, anxiety, family issues, coping skills, child abuse, whatever it may be. We've got to have mechanisms to provide a helping hand and avoid them from getting on opiate because it sedates them or makes them go away from their problems. I'm not going to mention all those. You can look at it. But when it comes to the summary of levels of evidence, the best evidence really is for exercise, multidisciplinary programs. Acupuncture has some evidence, and mindfulness-based stress reduction. When it comes to chronic pain, these are great things. There's also low quality evidence for all of these other things, so there's some evidence. disability management. When we have patients dealing with chronic pain, I think it's one of the things that is too often not addressed. What's the real meaning in your life? How has this affected your income? How are you, you see this. If somebody has a significant injury, spinal cord injury or even less, you see a big divergence. Some go on to tremendous recovery and are inspiring, and others go off the deep end, suicide, severe depression, dependency, similar injuries. But somehow there's a lot going on within their psychology. And what do we do as health professionals to help them? What kind of tools do we have? I'm going to go through these. And I want to finish, because we still have a couple minutes left. I want to finish with the video here. We educated all of our physicians. I think this pertains well to all of the people in this room. It's very entertaining. It's 5 minutes. But it tells you everything in 5 minutes that you need to know. And for our patients, when we have patients on chronic opiates, we had them watch this video as part of their annual visit. And I think it really summarizes and puts this whole chronic pain issue in perspective. It actually came out from the Australian Disability Management Program. Let's see if we can get that going.
We now know that pain is 100% of the time produced by the brain. This includes all pain, no matter how it feels, sharp, dull, strong, mild, and no matter how long you've had it. You might have had it for a few weeks or months. This is called acute pain, and it's common with tissue damage, say from back injury or ankle sprain. And generally, we'll be encouraged to stay active and gradually get back to doing all your normal things, including work. Or you might have had it for 3 months or more, and this pain is generally called persistent or chronic, because in this type of pain, tissue damage is not the main issue. What's less clear, though, is when you're told you have chronic pain, is knowing what's best to do about it. Well, in Australia, chronic pain is a really big problem. In fact, 1 in 5 people have it. Having a brain that keeps on producing pain, even after the body tissues are restored and out of danger, is no fun. Some people say it still feels like they must have something wrong. But that's just it. Once anything dangerous is ruled out, health professionals can explain that most things in the body are healed, as well as they can be by 3 to 6 months. So, ongoing pain being produced by the brain is less about structural changes in the body and more about the sensitivity of the nervous system. In other words, it's more complex. So to try and figure out what's going on, you need to retrain the brain and nervous system. To do this, it's helpful to look at all the things that affect the nervous system and maybe contributing to your individual pain experience. What can help is to look at persistent pain from a broad perspective, and by using a structured approach and plan, it's less likely that anything important will be missed. Let's start with the medical side. Firstly, taking medication can help, but only to a limited extent. It is the more active approaches that are necessary to retrain the brain. So using medications to get going is okay, and then mostly they can be tapered and ceased. Some people also think surgery might be the answer, but when it comes to a complex problem like chronic pain, surgery may not be helpful. So if you're thinking of surgery, it's best to get a second opinion, and remember to consider all the things. Next, it is helpful to consider how your thoughts and emotions are affecting your nervous system. Pain really impacts on people's lives, and this can have a big effect on your mood and stress levels. All those thoughts and beliefs are brain impulses too, but you can learn ways to reduce stress and wind down the nervous system. This helps with emotional well-being and can reduce pain as well. The third area to consider is the role of diet and lifestyle. Now, it turns out that our modern lifestyle may not be so good for us. In fact, what we eat and how we live may really be contributing to a sensitized nervous system. Looking at all the things like smoking, nutrition, alcohol, and activity levels, and seeing if there are any issues is a good beginning, and these things can guide your plan. Then there's often enormous value in exploring the deeper meaning of pain and the surrounding personal story. By stepping back and looking at all the things that were happening around the time the pain developed, many people with pain can make useful links between a worrying period of life and a worsening pain picture. For many, recognizing deeper emotions can be part of the healing process. Last but by no means least is physical activity and function. From the brain's perspective, getting moving at comfortable levels without fear and where the brain is not protected by pain is best, and you'll gradually restore your body's tissues. So to sum up, pain, it comes from the brain and it can be retrained, and when looked at from a whole person or broad perspective, gives you a lot of opportunities to begin. So get a helping hand if you need it, set a goal, and begin.
All right, that's it. Thank you for indulging. Thank you for being here.
So we're going to set up some chairs up here for our panelists. And if you have questions, Irene is going to go around and collect those. You can just let them look right probably in front of it. We're going to have you guys share the mic here.
Good.
So, maybe.
Can you go over the podium?
So the first question is for John. You mentioned as a pharmacist, you have a collaborative agreement. Can you tell us more about the rules for pharmacists Do you need the collaborative agreement only for injections or what services?
Not necessarily. The collaborative practice agreement is separate necessarily from just giving the injection. I can give the injection upon the order for the prescription itself, and that being sufficient. We do have standing order that we will have signed by some of our practitioners we work with, whereas the collaborative practice agreement is a little bit more complex that would kind of outline the scope of the role of the pharmacist, the limitations therein. And as far as the injection itself, we do have by state law the need for the training that's specific to non-vaccine injections, and once that is passed and certified, so long as the order stands for pharmacists to inject, whether it's a standing order for something like a flu shot or something that's specific to an injection like the Vivitrol, we're good to administer. No, not necessarily for just giving the injection. It's just a different tool to better integrate with the overall treatment plan. So if you have one established, it's more accessibility to the patient and a little more ability to provide a breadth of service rather than just taking the needle and putting it into the glutes.
Okay, our next question is for Brian. What can you tell the audience about dry needling for pain?
Dry needling is, it's one of the many different processes for physical therapy that are used. It's really the insertion of needles into sore muscle tissue to stimulate some kind of healing or relaxation of that muscle. It's really come into vogue, I would say, over the last 3 to 5 years. I've seen lots more of it. I have approached it sort of cautiously and judiciously. Many of my patients have requested it. Many have gone to it. A reasonable number have had good outcomes from it. So I think it's something that's in the repertoire. And I don't know if I have a whole lot more to say about it than that. And I really haven't seen any real bad outcomes. I've seen some good success, whether it's time or the dry needling, I'm not sure, but it has been effective for some patients. Good question.
And then Brian, this question too. So if someone is an opiate in recovery and needing surgery, how do they talk to their doctor about their addiction and knowing that most doctors would prescribe an opioid for the pain after the surgery?
It's a very great question. And at the University of Minnesota, I believe it was Minnesota, did a great study where they actually took those patients who are not opiate naive, and there's lots of them, some on high-dose opiates, and used that as sort of, now we have sort of this patient in capture, and worked with them on an overall taper plan and treatment plan, and we're pretty effective in using that as a hallmark to get them off of their opiates. One of the big issues you have is that when you take these patients and you put them into operations and they're not opiate naive, pain control postoperatively is a tremendous problem. And there's not a single formula on how to treat that, and what happens is they get dosed, when they come out in the hospital, and then get their dose when they're discharged from the hospital. We try to, essentially, take that out of the surgeon's hands because it was too complex for them, and identify and create an integrated approach to help them with that. And that's really what these patients need, and it does need to be identified ahead of time. So other than empowering them and having them have that discussion, if the doctors are looking at it, they should know, they can look at the chart very easily and know that this is not an opiate naive patient, and this is going to be problematic, and they should have a plan. But I think it's important for that patient to have the discussion. Does that kind of make sense? Is there anything else more particular about that? But it's a big problem. No question about it.
And then Scott, I'll ask you, and hopefully not put you on the spot, but we know that, and we've talked about this often, is that Wisconsin does have a very open legislation to look at changes. As people are working in this area and they identify things that maybe needs a legislation, how would they go about and help making legislators know, but also what is the process of moving legislation across the board?
Well, I think right now, in the past we had the champion John Nygren, who was really taking on a lot of the opioid-related issues, and he's kind of taken a step back, and now they have a new committee that's going to be dealing with drug-related issues, and they're trying to look at it more comprehensively, not just dealing with opioids, but whatever drug it is that might be ailing you. And I think the best way to do is to get onto the agenda of this committee and bring your issue forth to that committee, and then see if you can get the ear of somebody who's really going to champion your cause. And it really, it's up to you finding the champion to really move it forward. There's nothing that we could do as state staff to really get laws enacted. We really basically take a backseat to that kind of activity.
So if a pharmacist is interested in moving forward with doing Vivitrol out of their office, what would you say are some of the first steps for them?
Well, one of the first steps might be to find a good coordination point, for example, with LA Health that we have worked with, establishing with a prescriber that would have access to patients and also have a need for injection. Another would be to look for folks that say, the Department of Health in your county or community, as we have seen many grants are out there. Many counties have been receiving money to deal with this, and a lot of folks have no idea how to spend it. There are plenty of candidates just waiting, whether it's in jails or folks who are already seeing counselors through a court system and need to have access to treatment. Contacting folks in those health departments might be a great way just to get the ball rolling as well.
All right, that is all the questions we have for tonight. So just as a reminder, this has been recorded. So tomorrow, an email will be sent to you with the survey and the link to this, so you can share it with your friends and peers. I just want to do another round of applause for our presenters tonight.